I am lucky to have this presentation after TCT, otherwise my slides would have looked like 1 year before. And also I'm lucky to have this presentation after the presentation of Victor, because he showed us why we should pay attention to these techniques. Cutting and scoring balloon, I have presented here the two kinds of them. So one is, has knives, has aterotomes on it, metal aterotomes, and the other one has wire, nitinol wires. And both these add-on components are expected to disrupt the neointima or the plaque. So these are the recommendations of Antonio Colombo here. You can use them interchangeably, so in all the situations probably, but the main scenarios where we use them is in-stent restenosis and calcified lesions. So for in-stent restenosis, there are little data about that. This is the only study that has looked at the additive effect of scoring balloons in patients with in-stent restenosis before the use of drug-coated balloon. ESA Desire 4 was relatively small, but small are all the in-stent restenosis trials in general. 252 patients were randomized between scoring balloon or non-compliant balloon before the use of DCB. All of them had angiographic follow-up, which was very important to look at the differences within this small sample size. And you see here, the main result was a reduction of binary restenosis from 32% to 18%, which was significant. There was also a drastic reduction, more than 25–30%, of target lesion revascularization, but due to the small numbers, it didn't reach the significance. But much more needed are cutting and scoring balloons in calcified lesions due to the presence in more and more patients of these lesion characteristics. So this is the first randomized trials looking at scoring balloon, cutting balloon, and scoring balloon versus non-compliant balloon, which was the typical, the conventional treatment for this kind of lesions. And you see here a small trials with only 100 patients showing that there was a benefit in minimal stent area with the use of scoring balloon versus non-compliant balloon. And also, extensity index was better for the patient who received the scoring balloon. This is another approach. The investigators here compared scoring balloon with rotational atherectomy in also here in 200 patients. And you see the differences in procedural success, which was significantly better with rotational atherectomy as compared to scoring balloons. But the results at 5 years were not significantly different. I have to say here that the investigators allowed in this trial also crossing over to rotational atherectomy, which was the case for those who didn't have a successful procedure at the end. So we cannot say that, without allowing the crossover, the result would have been the same. And now we have the shortcut trial presented at the last TCT, which is a comparison of cutting balloon versus intravascular lithotripsy. And it's a large trial, 413 patients with significantly calcified coronary artery disease, undergoing also IVUS-guided PCI. The patients were stratified in two groups, in patients in whom there was a planned rotational atherectomy and in patients without a planned rotational atherectomy, 200 in each group. And both these strata were randomized between cutting balloon and shock wave. At the end, all patients received drug-eluting stents. The primary endpoint of the trial was post-procedural minimal stent area at the site of maximum calcium. These are some characteristics of the calcifications of the lesions. Nodular calcification was present in 1/4 of the patients. And also you see here the maximum arc of calcium in this that was more than 340 grades. This is the primary study endpoint for the total cohort, irrespective of they had atherectomy or not, rotational atherectomy or not. You see that the trial was able to confirm the non-inferiority of the cutting balloon versus IVL for the primary endpoint. If you look at the clinical events, you see no difference at all, but you don't expect for these small trials to have there. But what is important is that abrupt closure didn't happen in this cohort. Perforation was only present in one patient treated with cutting balloon, and in hospital, both in hospital and 30-day MACE were not significantly different between the two groups. What was significantly different were the costs. So you have more than $13,000 in the group of IVL, and you have less than $10,000 in the group of scoring balloon. If you look at the two strata, that means patients who were planned to have atherectomy, in this subgroup of patients, there was no difference at all in the minimal stent area. In the other strata, in those patients who were not planned to get atherectomy, it was not possible to confirm non-inferiority of the scoring balloon versus IVL. That means that IVL looked better than scoring balloons. But we don't have, in these small stratas, we don't have clinical differences between the two approaches. For both atherectomy and non-atherectomy strata. And here also, you have differences in the price, which was much higher for the IVL group as compared to the scoring balloon in both cases, in those with atherectomy and those without atherectomy. Now, the ultra or super high pressure balloon, OPN balloon, it is also called. You have here the characteristic, the main characteristic of OPN balloon is to have a double layer balloon which resists very high pressure, more than 40 atmospheres and ultimately also 50 atmospheres. It should be mentioned here that it is also precautions to have balloon 0.5 millimeters smaller than the vessel size in order to prevent complications. This is the first comparison between OPN versus scoring balloon. It was the ISAR-CALC trial, a very small trial, less than 90 patients. But the primary endpoint allowed to see the extensity of the vessel after stenting, and also some indexes of lumen diameters. For the primary endpoint, there was no significant difference between the two groups. That means that OPN was not superior to scoring balloon. But in terms of the minimal lumen diameter, OPN balloon was superior to a scoring balloon. You have also seen the results of the VICTORY OPN versus IVL trial. This is the first comparison between OPN and the IVL. It was more than 270 patients trial, which were randomized between OPN and IVL. At the end, all patients got stent implantations with second-generation drug-eluting stent. Post-PCI, there was OCT done, and the final stent expansion was measured as the primary endpoint. In addition, the investigators looked also at the clinical follow-up at 30 days. Here are some characteristics of the procedural data here. And you don't see big differences, but the number of devices used was higher for the OPN than for IVL. The trial was was able to confirm the non-inferiority of OPN balloon versus IVL in terms of the primary endpoint stent expansion. At the end, there were also no differences in clinical outcomes, but you have to consider here also the relatively reduced number of patients. We are following another approach in evaluating the IVL. We are not comparing IVL versus one certain methods, one certain approach, let's say OPN or scoring balloon. We are looking at the comparison between IVL versus everything else. So you are free to use in the control group whichever method. The trial is planned to include 666 patients, and we have now, this week, we have enrolled 250 patients. We are looking at the primary outcome at 1 year, which is the typical clinical outcome, the combination of all adverse events. Thank you very much.